our keynote speaker this morning that I want to introduce to you. He is well known in the hospital circles, not so much as much in the physician side of things, but we are very excited to have Nathan Kaufman with us, who's the Managing Director of Kaufman Strategic Advisors. He's located in San Diego.
Here are my notes. First, I want to make two apologies. First, you'll notice I have laryngitis. I tried to deal with it. I went to the Z-Pack store, or as you people would call it, the Urgent Care Center. And hopefully it's starting to work on my virus. The second point I want to make is this is death by PowerPoint. I don't really have any notes, so you're going to see them. If you want any slides, you're welcome to them. As mentioned, I spent a lot of time negotiating, about 80% on behalf of hospitals with physicians and about 20% representing physicians. You'll be proud to know that orthopedic surgeons are the most formidable negotiators of any specialty that I have to deal with, which is both good and bad. It's bad because it's really hard to negotiate with you. It's good because it takes a long time and I get paid by the hour. So you put my kids through college. I really appreciate it. So we're going to talk about this stuff. I'm going to run through it fairly quickly. I will be doing market research up at the bar this evening, so if you have any questions, feel free. I was born in 1953. I'm 63 years old. Those of you who aren't 63 or haven't become 60 yet, when you become 60, you start looking at the healthcare system differently, like, hey, I'm going to use that thing soon. And as I look at it, I have a concierge physician because I don't trust the system very much. And I think there's a lot of room for improvement. By the way, this is a 1953 Chrysler New Yorker. This was a car that was manufactured the year I was born, and this is what something that was created in 1953 looks like when it's kept up in good condition, but this is how I feel. And that basically has something to do with my days in college, which I won't go into at this point. Now, one of the things, I know hospitals really well. I visit about 85 a year, and I think this point, and my old eyes, it's hard to see. This is a great quote. It says, "In times of change and uncertainty, managers look for simple solutions to complex problems and thus are incurably susceptible to panacea peddlers." You watch your CEOs and they're chasing every shiny object that appears. You hear about population health and they call up consultants and they say, do we need to do anything in population health? And the consultants say, of course you do. And by the way, we have a practice and we can help you right away. The second point I want to make is, and it's important, is don't do bad deals. Bad deals never turn out well over the long term. And that even means really favorable deals, because when there are really favorable deals, one of two things happen. The corporate counsel eventually steps in and says, Stark and fraud and abuse, and you have a problem, or the hospital just can't afford it. So try to do deals that are fair for both sides. Obviously, you want to make it advantageous, but that's just a caution. So I usually give this quiz. In the future, being a successful healthcare provider will be A, easier than today, a little teeny bit harder, or exceptionally complex and difficult. And most people say C, complex and difficult, and the reason I bring this up is I predicted this in 2005. This was my presentation to the American College of Healthcare Executives. It was very obvious that we were going to have difficult times in healthcare. And the reason for that, in fact, they used to call me Neutron Nate or Dr. Doom, because I was saying this is going to be a really difficult time. And by the way, it's going to get more difficult. There's nothing in the previous administration or the current administration that's going to solve our nation's healthcare crisis. And if you look at the math, and I'll show you the math, eventually reality catches up with the math. It happened in the housing industry, if you all remember. Gary Schilling, a hero of mine, predicted in 2002 that the housing bubble would soon go bust and it would affect everyone. Of course, the realtors said, no, it's not. 2007, it did go bust, and it was all based on the math. So how did we get here? Why do we have such a problem? Oh, good news, we just hit $3.4 trillion of healthcare spend. Almost one out of every $5 that's spent in this country is spent on healthcare today. And the reason we got here has a lot to do with cattle and sheep. You all know that already, right? But basically this guy, Garrett Hardin, he studied colonial times and the economies of colonial times. And there was a thing called the Boston Commons, and back then it wasn't a bunch of restaurants. In fact, what it was a pasture. And it was free. So if you had a herd of cattle, you could take that herd over to the Boston Commons and they would essentially, they'd graze and then you'd take them back to your farm. And so what ended up happening, everybody acted in their rationally and in their own self-interest. And hey, the more cattle, the more money I make. And the expenses, there's no expense really because you could graze them for nothing. And so they all build their herd. And sooner or later something happened. And what happened was they overgrazed the pasture. And then there was a tragedy. So Garrett Hardin came up with this term called the tragedy of the commons. And they all had a choice at that point in time. Well, a couple choices. They could end up having their cattle die of malnutrition. They could all sit down, sing Kumbaya, and work out mutual sacrifice. Or there had to be regulation. Now, how does that relate to healthcare? Well, we have a pasture, and the pasture is called the healthcare dollar. It's currently $3.4 trillion large. We've moved the fences every year. We can't move them any farther. And we have three choices. All of us can get, anybody here from the pharmaceutical industry? All of us, including those pirates from the pharmaceutical industry. We could all sit down and work together and mutually sacrifice and, and solve this problem. Or there's got to be regulation. One interesting fun fact is 1 out of 10 jobs or 9 jobs in this country are in healthcare. And what happens if there's regulation and healthcare, which they will, providers like hospitals have to close, that's going to increase unemployment, which is going to get interesting. But inevitably, we have this tragedy of the commons, and it's not getting better, and we continue to overgraze, and I put consultants in there as well. Hey, the healthcare dollar was free. Let's take as much as we can. We just have to do work, and it's really unlimited. Well, that's coming to an end. So one of the things I want to talk about is the brutal facts that exist in our healthcare, because if you don't understand the brutal facts, you can't prepare for them. And so let's start with what's happening with the new administration. The first thing you have to understand in the new administration is they want to reduce the cost of healthcare. Well, the only thing that can't move is a hospital. You all can move to a new town, home health can move, the insurance companies can quit providing premiums in a particular market, but the hospital can't move, so they're sitting ducks. They're sitting ducks. In Connecticut, they imposed a 6% hospital tax. They're cutting Medicaid reimbursement to the point where it costs more to send a bill to Medicaid than what you get reimbursed. So one of the things we know is that the hospitals are probably going to get hit pretty hard in whatever they come up with. The second thing is that MACRA will not be repealed. And we'll talk about MACRA. It's not going away. It had almost universal support. You may want to talk to the American Medical Association about trading the SGR for MACRA and what it all means, but it's probably not going to go away. There will be some form of pay for value. We don't know what it's going to look like. It's probably not going to be capitation, which is good based on our experience, as you'll see in a few minutes. Coverage will not be expanded. They're talking about block grants, just giving the states a bunch of money. Well, if they give the states a bunch of money, it's going to be a fixed amount, and the probability is if they do expand coverage, they're going to reduce reimbursement even more. Affordability is still an issue. 51% of the patients owe more than $1,000 to a healthcare provider, and that's not getting any better. Free market competition may increase. Medicare Advantage, 1 out of every 3 people over, I can't call them elderly anymore, people over 65 are enrolled in Medicare Advantage. I'll explain why. And Medicaid managed care is becoming really popular. But see, you're obligated to take a Medicaid patient, and the Supreme Court says you have to accept the rate the state gives you. But when they give it to a managed care company, you don't have to contract with them. And so what's happening under Medicaid managed care is access is becoming an issue. And there's theoretically going to be more consumer choice. But the bottom line is healthcare is 25% of the federal budget. It's going up. Here's a fun fact. If we saved $50 billion in Medicare, it would move us a year and a half back. That's it, a year and a half back. It would move Medicaid 1 year back. So we haven't solved the problem, and after the legislation is presented, it's still going to be an issue that Trump or the next administration is going to have to deal with. So here's the initial, this is a quote, initial results of value-based purchasing, all that stuff the government has created, show modest effects on Medicare payments and no apparent change in quality. That's blasphemy. Who the heck said that? Only the Government Accounting Office. I'm in favor of the Affordable Care Act because it covered 30 million Americans that weren't covered. The only problem is it doesn't work. And we have to do something different. And you look at the financial forecasting, the major benefit of financial forecasting is that it makes astrology look respectable. So far, this is the literature, CMS demonstration projects have not made significant impact on spending. And pay-for-performance studies are really subjected to a history bias. In other words, quality or costs were already coming down, in part because the government said, hey, that's no longer an admission, that's an observation day. So they reduced the cost. It wasn't necessarily about the Affordable Care Act. And so Mark Twain had a statement that I like to kind of steal and modify. There are lies, damn lies, and government statistics. For example, they say, hey, great news, readmissions have gone down significantly. Well, 40% of the reason readmissions have gone down is because they're no longer called admissions, they're called observation days. So when you look at the data, the top line is hospitals, then the next line is physicians. I'm not sure I see a trend there in decreasing reimbursement. Every hour, 400 baby boomers turn 65. And as the population ages, regardless of the cost per population declining, the healthcare costs are going up. And right now we're at a 5.8% growth rate, which means in about 12 years, healthcare costs will double. We'll go to $6.8 trillion of cost. Now you tell me how that's sustainable. So what's the problem? They compared on the right side the cost of healthcare for metropolitan areas, and they compare in industrialized countries to our country, and you can see that we spend twice as much as any other country. And oh, by the way, they predict by 2030, but because the trend is that way, we'll have the lowest life expectancy of any industrialized country. And we're spending twice as much. And where are we spending it? 60% on paying people, everybody from consultants, lawyers to doctors, a lot more than their peers in other countries. So you have to assume that if healthcare costs are going to go down, they have to deal with how much they pay or the rate of payment, and 40% in terms of excess utilization. Now, a couple things. Number one, you are being graded right now based on a thing called MSPB, Medicare Spend Per Beneficiary. And the difference between one physician's spending and another physician's spending has to do with SNF utilization, almost 100%. So if you personally or your group doesn't have a plan, Medicare pays for 26 days of SNF after an admission. And it's a miracle how all the Medicare patients end up staying in skilled nursing facilities for 26 days once they're admitted. So you need to have a SNF strategy if you are going to be viewed as a low-cost provider. The second thing, I live in San Diego, if everybody in the country used hospitals the way we do in California, you would see a 30% reduction in utilization, which means there's a lot of hospitals that are going to be in trouble over the next couple of years as payment is ratcheted down and as utilization declines as well. So one of the things I tell every healthcare provider is focus on cost. We're not going to see a lot, you're already at capacity, we're not going to see a lot of rate increases. They're going to get rid of out-of-network loopholes over time. And so focus on cost in your practice in terms of how you practice clinically And also portfolio rationalization. Don't have two offices next to each other in different buildings. You need to rationalize everything you do to make sure that your practice is the most efficient as possible. So one of the things that's for sure is that a lot of stuff, including knees and hips, that used to be done on an inpatient basis are going outpatient. And so when you look at smaller hospitals, the reason for inpatient beds doesn't exist any longer. Hospitals in the future are going to have to excel in emergency, neurosurgery, obstetrics, acute and critical care cardiology, and subspecialty surgery, including some orthopedics, although a lot of orthopedics is going out. And one of the things that people don't understand, I tell people all the time, you don't understand healthcare until you negotiate call pay with an orthopedic surgeon. You have no idea what healthcare is really like. What's happened is the entire hospital-based physician industry or cottage industry is becoming a lot more sophisticated and corporate-like. So it used to be you'd have a local anesthesia group. Now you don't have a local group, they're part of a corporation. The anesthesiologists still want to get paid as much as they did before. So where's the profits from the corporation come? From a subsidy for the hospital. Can a rural hospital, I had one anesthesia group say, either give us a subsidy of $600,000 a year or we're going to leave on July 1. And I said, what about, population health and all that other stuff? They said, no, we're leaving on July 1 if you don't give me a subsidy. And so all of these factors are going to drive smaller hospitals into some severe economic pressure. I've identified 4 reasons that hospitals underperform, and let me go through them. The first one is governance, the board of trustees. Here's an example. MD Anderson laid off 1,000 employees and the same week gave their CEO a $200,000 bonus. Where's the board of directors in this? I mean, how can you do that? And it gets even worse. Look what the CFO of MD Anderson said. It said, our operating deficit for 4 months is nearly $170 million. We're not yet seeing the appropriate balance of revenue and expenses. Well, let me explain something to that CFO. The whole job of management is to balance revenue and expenses. That's their job. Not to, I call this weatherman management. Well, it's getting cold outside, nothing we can do about it. The third thing is system management. Especially the religious systems, a lot of them are circling the drain. A lot of them are having severe problems. Providence Healthcare System, which is about a $16 billion system, made less money last year than Hospital Corporation of America made in their Coke machines in Nashville. Think about that. The fourth thing is franchise. If you're in a bad location, it's not going to get better. Those days of turnaround hospitals are over. And what really scares me are those hospitals that happen to be in a good position, a good location, and the population grew around them, and they think they're really good managers. We call them third basers. They were born on third base and thought they hit a triple. They're going to experience some severe financial pressure. So very quickly, what you're seeing right now is the average hospital loses $82 per adjusted admission. And if you break that down by geography, you really don't want to be in the Northeast unless you have to. It says, look, you want to be part of a system. But it turns out that it's the for-profit systems that are actually driving the benefit of system affiliation. You want to be a regional power. You don't want to be a rural hospital, that's for sure. They're losing tons of money. You don't want to be a small hospital. Minor teaching makes sense. You want to have a short length of stay, which is why you get pressure there. You don't want a large percentage of Medicare, and you want to be a low-cost facility. So when you look at it, what's going to determine a hospital survival is if they're a regional power, if they're not rural, if they are large, if they have short lengths of stay, if they have low Medicare, and if they're able to manage their cost. So we're going to see a significant percentage of hospitals in financial trouble. And to exacerbate the problem, if you look at markets like New Orleans and South Dakota, the physicians have left and basically cherry-picked, and I would do it too because it's the commons, probably some of the best, most profitable patients, which means even these hospitals are going to struggle over time. And I hear this all the time. Either you have to be part of a $4 billion system or I hear this from boards. We want to stay independent. Independent ownership is not a strategy. The question they need to ask is, how do we control cost, care, capital, be competitive, and comply? I think there's a typo there. But the point here is that's true for your medical practices as well, or your orthopedic practices. These are the questions you have to ask. How do we optimize those things so that we can weather whatever storm happens? Now, if you were a government official and you wanted to reduce healthcare costs, let's see, what are the biggest targets here? Clearly, they're going to go after hospitals and physicians. And the unfortunate thing is that most regulators don't understand this. One of the things is that people say, well, let's get rid of the insurance companies. Well, the actual profits that insurance companies make and overhead is about 3% of spending. But what most people don't understand is that about 7% of this, about a third of the supply costs in hospitals are also drugs. And yet they have the strongest lobby probably in the country. And so the likelihood is we're going to see a lot more pressure on hospitals and physicians. And even if you're not employed, and we'll talk about that nightmare in a minute, even if you're not employed by the hospital, you're probably getting call pay or directorships or something else. And the hospital right now is the goose that lays the golden egg. And the challenge that I have failed at miserably is trying to convince physicians that they need to support the hospital so that the physicians continue to get paid and have a good hospital to practice in. And it's just a real challenge. Even employed physicians, I always say, yeah, that physician's employed by that health system, but they don't work for them. So there's a fine line between a strategy and a hallucination, and what we see my colleagues doing in the healthcare, in the hospital business, is a lot of hallucination. 38% of the CEOs say the only way to solve our problem is we're going to create our own health plan. Well, let's see how that's working. Piedmont lost $30 million on their Medicare Advantage plan before they closed it down. Mountain State's about $40 million. Mercy, Ohio bought Kaiser Permanente and lost $150 million a year until they closed it down. Mass General lost $100 million a year buying Neighborhood Health Plan. And Boeing, which is the famous, Boeing said, we're going to give you a budget, Roper St. Francis and Swedish Hospital. If you beat the budget, you keep the difference. If you miss the budget, you eat the higher cost. And it's been an absolute disaster. And then there's Sutter Healthcare, which is the famous, very profitable system in Northern California. And they just fired their 2 top executives from their health plan not because they're not enrolling people, they've enrolled 38,000 people, but because they're losing tens of millions of dollars of money. So I read that health plan's annual report, and the CEO said the following: as the industry shifts from fee-for-service to value-based care, whenever I hear a CEO say that, I want to jump in a foxhole, because Lord knows what's going to come next. Let's go back and focus on managing our health systems. Let's focus on that and quit trying to follow these shiny objects. By the way, if you want to be a payer, this is what you have to do well, because this is what our payers do well. They mitigate actuarial risk. They leave the market. They pay claims. More than paying claims, they deny claims. They cut reimbursement. They raise premiums, and they increase deductibles. That's what they do well. So if you want to be in the health plan business today, that's what you have to do. But one of the things, why do health plans exist? They exist because we in the provider community, by default, have delegated provider selection, quality, payment, rate, and appropriateness to the health plans. My doctor does not decide which medication I get. It's either approved or disapproved by the health plan. Same thing with MRIs. And one of the things that really we have to start doing is we have to take responsibility and demonstrate to the employers, hey, we don't need somebody monitoring how we provide care, because we have data here to show that we're hugely efficient. So when I look at the state of the art between payers and providers, the payers are saying, let's collaborate and work together. This is kind of how I envision that relationship. In Connecticut, Anthem asked for like a 26% increase in their exchange premium, and they're offering doctors 0 to 2% to minus. How is that a collaboration? But there is good news. I actually have a little good news every once in a while. And the good news is that based on the large medical groups that were recently surveyed, they don't believe fee-for-service is going to transform to anything else for a long time. Now, if you have a fee-for-service contract and 5% of that contract is based on value, whatever that means, that's not a value-based contract. That's fee-for-service. One of the scary things is the United Healthcare just bought Surgical Care Affiliates. And so the health plans are beginning to eke into the provider business. In fact, there's a company called Amwell, which is a virtual medicine, telemedicine company, where you can call in, talk to a physician for $40 and get diagnosed. The fact is that those physicians are employed by Anthem Blue Cross. So we have this kind of collision course between the government's idea about how to pay physicians. They think you're mortgage brokers. You know, if they change the way you pay, you're going to change the way you practice medicine, which is not true. In fact, these professors who study this said health professionals do not respond to economic carrots and sticks like rats and mazes. They said to teachers, hey, let's do this. If your kids get better grades on the standardized tests, we're going to give you a bonus. So what did the teachers do? They taught to the test. They didn't educate the kids better. And there's nobody smarter than physicians able to find loopholes and ways around things that are presented to them. Oh, by the way, Health and Human Services Secretary Burwell, who's no longer there, when interviewed in the LA Times and asked about value-based purchasing and the Affordable Care Act, she said, medical providers want this. That's the quote. How many of you want this? I want a piece of it, the coverage piece, but basically everything else, not so much. So when you look at the physician world, this is based on 17,000 surveys. What do we see? 80% of the physicians say their practices are at capacity. 43% said they self-refer to specialists. Can you imagine if those people had to go see primary care physicians, of which we have a 64,000 shortage? As one of the orthopedic surgeons that I negotiated with said, we are primary care physicians for bones. And so it doesn't make sense necessarily to go to primary care physicians for that problem. They don't have the time they need to take care of their patients. There's low morale. 50% said low morale. A lot of them are trying to go into concierge medicine or leave and become medical directors or something else. And 30% aren't participating in Medicare and Medicaid. Here's a new fun fact. 1 out of every 5 emergency physicians in this country are not participating in a health plan, and thus their patients are getting surprise bills that are sometimes 6 to 8 times Medicare, and they're expected to pay for it. Even though the hospital is in network, the ED doctors aren't. By the way, it's 1 out of 3 in Texas. So again, when you look at the healthcare system, something has to change, and unfortunately it has to be regulation. Now, this is a little bit old data, but it's still relevant today. It turns out that 1% of the population consumes 20% of healthcare, and 5% consumes half of healthcare. That's where we need to spend our time to reduce the cost of care. But what are we doing? We're giving folks deductibles. So here's some fun facts. Almost half of Americans, according to the Federal Reserve, don't have the money on hand to cover a $400 emergency. How are they going to cover a $1,200 deductible? And so what they're doing, about 1/3 of the patients admit, what they do is they wait till they become train wrecks, show up in the ED, expect you to treat them, and stiff you for the deductible. That's the game that deductibles are playing. In fact, what's happening is people are avoiding preventive care because they don't want to pay the deductible. The whole thing's opposite. So when they talk about consumerism and empowering the consumer, it turns out that this 5% that consume 50% of the cost, they don't shop. Once they're in the system, they don't shop. What they are shopping for, by the way, is are you in network or out of network? And the problem is there's lawsuits about that because one day a physician's in network, the next day they're out of network. I would argue that hips and knees and some elective orthopedics will be shopped. We already see it in San Diego, in California. Kroger's grocery store is sending all their hips and knees down to Hoag Orthopedic Hospital. The large pension fund in California, CalPERS, is saying to all of their patients, here's $30,000 for your hip and knee replacement. Go wherever you want and you pay the difference. We're going to see bidding, I believe, for hips and knees in the future. So you want to make sure that you're as efficient and high quality as possible so you can give those people the appropriate data. Getting enrollees to make higher value decisions remains a mirage. Most people are not shopping. And wellness, I love wellness programs. The concept basically is if we keep people healthy, then the cost will go down. The fast food industry has a thing called the craveability index, where they try to get everybody hooked on their food by adding sugar and fat and salt. By the way, the food that has the highest craveability index in our country is a Krispy Kreme donut. It's impossible for a human being to eat one Krispy Kreme donut. It's just impossible, and they do that on purpose. So I have the doctor's dilemma. Now, what the doctor's dilemma is, the doctor is saying to this patient, if you don't change what you've been doing for the last 40 years, there's a high probability something bad's going to happen. I don't know when, and it's not for sure, so change. And the patient says, well, sometimes I have trouble breathing and have chest pain, but right now I feel great. What's with all this doom and gloom? So the idea is if people will just stay healthy, then we can avoid healthcare costs. So let's take a look at how we're doing. This is the obesity rate. That's the child obesity rate in green, and that's the adult obesity rate. It's approaching 60% in Mississippi, by the way. 2 out of every 3 people in the population drinks a sugar drink every day. 1 out of every 4 kids eat fast food every day. And by the way, if you want to know about obesity and its relationship to poor health, there's 77 million websites that you can go to. So wellness really isn't working. But for me, what I'm saying is, I go to physicians and I say, if you don't change what you're doing for the last 40 years, there's a high probability something bad's going to happen. I don't know when, and it's not for sure, so change. And I have the same luck under most circumstances. Now, again, getting back to Secretary Burwell, her idea was to make patients healthier by transforming how doctors get paid. And if that ever happened, I'd like to introduce you to your new competitor. It's a Cheetos chicken fries from Burger King. So luckily, she's gone. Moody's, the folks that rate bonds, what they say is that size matters. That the thing is to get really big, and if you're really big, you're going to do really well. So these experts did an analysis of, so basically these folks did an analysis on the big hospital mergers, and what happens is when hospitals merge, the big hospital that has better rates applies those rates to the little hospitals, and costs actually go up. Not only that, but when you look at it, CHI, the largest, what was the largest in terms of hospitals, for-profit hospital chain, they're circling the drain. They've had to sell a bunch of hospitals. I don't think they're going to be around in another 3 or 4 years. Dignity, which is about I think a $12 billion health system, they went from an 8% profit margin to -2. And Catholic Health Initiatives is looking to sell its health plan business. Last year they lost $600 million. So you tell me that big is better. Now here's the fun part. Dignity and CHI, the top 2, they're in merger talks. You know the old Kmart 2-for-1 sale, 2 times crap is still crap? Sorry. I'm going to lose a lot of clients if you all go back and tell them this stuff, but anyhow. Physician employment is not going to change. One of the few specialties where physician employment is not really catching on is orthopedics. And the reason is you're able to supplement your incomes with surgery centers, PT, and in some cases, imaging, which makes it a lot better. But this is not going to stop. And if it doesn't stop, eventually one day, the hospitals will figure out how to get their primary care physicians to control their referrals to a particular specialty. And at that point in time, you want to be affiliated with the hospital. I tell all of my physician clients, hold your nose and go to the meetings. Figure out what the hospitals are doing, because this may happen at some point in time. Well, an orthopedic surgeon, I was doing market research at the bar in Hershey, Pennsylvania, and an orthopedic surgeon said to me, Nate, does a health system have the competency to manage a physician practice? And I said, no, absolutely not. Then I thought about it, and I asked myself the following question: do physicians have the competency to operate their own practices? I spent a good bit of time taking semi-bankrupt physician practices and getting them employed and saved so they won't disperse from the market. At least 50% of the practices that I see aren't really practices. They're just a bunch of condominiums that share revenues. They're not a multi-million-dollar business, and we'll talk about what that looks like. And then I asked the following question. It's going to be hard to see. This isn't the right question either. Here's the right question. In the most complex regulatory environment ever, does a health system have the competency to run a very large multi-specialty practice comprised of independent-minded physicians, many of whom are their biggest admitters, that own their own practices and reluctantly sought employment by the evil hospital primarily to preserve their incomes? That's the question. And then on top of that, they pay them the 75th percentile of MGMA, and when all the hospitals pay them the 75th percentile, that becomes the median. And when people come out of residency and they know their specialty and they've memorized the MGMA survey and come to you, they're going to be looking for that median. So one of the things I just want to bring up, if we're going to reduce costs, most people believe that about 45% of the potential cost reduction is actually in clinical standardization. I heard a brilliant physician, Dr. McCary from Johns Hopkins, speak. He wrote a book called Unaccountable. And so basically, here's the story that I used and how he responded. I had 25 cardiologists in a room, all in the same group, and I said, now go with me. There was a glitch in the electronic medical record. I know it never happens, but just make believe. And all of you came and examined me when I was in the emergency department. How many different sets of orders would be written by 25 different cardiologists? We concluded about 5. Now, one of them is going to be lower cost, one of them is going to be higher cost, one of them is going to be better outcomes, one of them is going to be worse outcomes. And I, as your patient, don't understand this. And by the way, nobody wants to buy highly variable care. Dr. McCary said the 6 most dangerous words in healthcare are, I like doing it my way. This guy Deming, who went to Japan when Made in Japan meant it was junk, he said, if I had to reduce my message for achieving excellence to just a few words, it would be, it all has to do with reducing variation. And the only people that can reduce variation is you. Or there'll be regulation. The other problem we have in healthcare is this. If you're in Massachusetts and you want to get a hip replacement, this is the bundled payment. The total cost, they add up the anesthesiologist, orthopedic surgeon, and hospital bill. It could cost you anywhere from $18,000 to $74,000. Well, if you're paying a lot more, like $74,000, I'm sure you're going to get better care and better outcomes. So these, I got to get some fuel. So these really smart researchers did a study. Here was the formula they used. I swear that was the formula. To determine why it was $74,000 versus $18,000, and here was their conclusion. Payment rates in a market vary by 400% and are primarily a function of market power, not value. So if I'm a physician getting in that $74,000 category, or a hospital, I'd want to think about the fact that the trend isn't going to be getting more money, probably less money, and now's a good time to reduce my cost structure by making my productivity more efficient, reducing supply costs, and standardizing how care is delivered based on the best practices that a particular group of specialists know. Another way of describing it is we're moving from cost-based reimbursement or cost-based pricing, meaning here's our cost, here's how we price our product, this is our compensation or profits, to what Drucker calls price-based costing. This is all you're going to get paid. You better get your cost structure down or you're going to be in trouble. And if you do this and the price doesn't come down, you've just made a significantly more compensation in the future. So focusing on cost and efficiency and productivity and supplies and clinical standardization will prepare you for the future under the worst circumstances. Under the best circumstances, it's going to increase compensation. We call that a no-regret strategy. And then there's macro. And again, here's some research. Consistently positive associations between pay for performance and health outcomes have not been demonstrated. I don't care what's going to happen next year or the year after in macro. This is what I'm concerned about, or this is the message. You as physicians are going to be evaluated on quality, resource use, improvement activities, and advancing care IT, meaning meaningful use. And your reimbursement, if you have a single tax ID, eventually will be subjected to a plus or minus 9, it starts at 4 and goes up to 9% penalty or reward based on how you perform in these categories. How many of you have seen your QRUR report? A bunch, that's good. If you haven't, you need to see it because the government is rating you on cost and quality. And the government and the primary care physicians, if you were primary care physicians, I'd say find out the cost of that the orthopedic surgeons are generating for their procedures. And if it's a high cost, a lot of sniff days and those kinds of things, you don't want to send your business to them because you will be viewed as a high cost per attributed life. So more and more there's going to be scrutiny on you with respect to that. And it's tax ID specific, and if you haven't standardized in your clinical practices, you have no control over that. On the other side is a thing called an APM, alternative payment model. Instead of doing it by a tax ID, what they're going to do is say if you get together in a cluster that's defined by the government, you will take group risk rather than individual risk. This is also known as an ACO. But it's plus or minus like $10 million, which means the hospital has to own it and let you govern it. But if you join one of these APMs, you will get guaranteed a 5% increase from Medicare every year. Where do you think the government wants you to go? They want you to stand up, or a health system to stand up a comprehensive, clinically integrated network, and they're giving you rewards and penalties to do so. Now, the only problem with the APMs is the American Association of ACOs, the National Association, said there's overwhelming evidence that two-sided ACO risk models are not viable for most. So the scary part is, if you want the doctors to get a guaranteed 5% increase, you got to go and you've got to take collective risk or group risk that the hospital is going to be responsible for, and probably is going to lose money on over the next couple years. Plus the fact that all this stuff costs about $40,000 a doctor in administrative costs today, which means that a number of small practices that still exist are going to disappear because they can't afford the overhead to deal with this mess. So what do? I've got 30 minutes to tell you what to do. Well, the first thing I just want to mention is this. I tell hospitals this all the time. The only way you can succeed in this new environment is if the practicing physicians lead. You have to win the hearts and minds of the practicing physicians because nothing good happens in health systems unless it's driven by practicing physicians. So here we are today, we're at fee-for-service and we want to move to value. And the question is, how do we do that? And a lot of my colleagues will tell you, well, you got to be like Uber and Amazon. If one more person says that, I'm going to start cutting myself. And the reason is, last year, Uber lost $3 billion. It took 20 years for Amazon to break even. So the real question is, what is the specific realistic transition plan that you can implement today? Where should you be focusing to be successful? A great TED Talk I listened to recently said that the 2 reasons that companies fail, and by the way, you are a business or a company. I know that because if your expenses exceed your revenues, you go out of business. So they say 2 reasons is, number 1, they only do more of the same, or number 2, they only do what's new. We see the hospitals doing only what's new, and the doctors do only the same. And you need to balance that. And you need to, and so when I think about it, I read this book called The Path. It's about applying ancient Chinese philosophy to modern times, and they said the world is fragmented, irrational, and in perpetual disorder. I changed that a little bit. Anybody want to argue that healthcare is fragmented, irrational, and in perpetual disorder? And yet when we plan, our plans look like this. Here's where we are today, and here's where we're going to be in 5 years, and then we look back, and it actually looks a heck of a lot more like this. Your plan is not a plan. Your plan is all about structuring or creating or modifying your organization such that it has the competencies, agility, discipline to adapt to whatever the heck comes next. If you told me 5 years ago that we had macro, I've been in healthcare 40 years, I would have told you you're nuts. So the question you have to ask about your own organization is, are we prepared to move as a single entity to deal with whatever comes next from the federal government or from the private payers or from Medicaid or whoever? Most important slide is this. We talk about value-based care. What the heck is value anyway? Value means that your benefits are worth your cost. The question you need to ask for your orthopedic group is, how are we going to be sustainably differently better than our competitors? How would we be sustainably differently better if the hospital hired 5 orthopedic surgeons? And if we're sustainably differently better, they would never want to do that. So we have benefits and costs, and there's 4 benefits: appropriateness and outcomes. Those are your responsibility. I don't know about those. See, when I get sick, I think I'm either having a heart attack or cancer. That's all I know. Okay? So I don't know about appropriateness. I don't know about outcomes. But you all are being measured by the payers, both government and private, in terms of, are you delivering appropriate care? Are you getting good outcomes? Us dummies, what we judge you on is service, but most important, access. Your medical group is being branded based on the service you provide the patients and the access. I'm on the board of a pediatric group. The thought of closing our office is at lunchtime. It's beyond the realm of possibility. Many of our patients are hourly workers. The only time they get off is lunch, or early morning, or late at night, or on weekends. And if we want to be sustainably differently better, we have to change our philosophy, because I'll tell you one thing. If I have a pain in my shoulder and I can't get in to see you within 24, 48 hours, I'm going someplace else. There's no loyalty when it comes to access. So when you look at appropriateness, Mayo Clinic has 153 care models. How many does your group have? And why don't you have 10 or 20? So that you can actually monitor how care is delivered and make sure that you're providing the most efficient, high quality, appropriate care that gives the best outcomes. As far as outcomes are concerned, if you have a heart attack, and this is true with knees and hips as well, if you do a lot of them, then the chances are reasonably good that your quality is better and your cost is lower than if you just do a few. And then there's service. My wife was really sick in November. We went to the urgent care center, and this was the sign that we saw. It will be 2 hours before you see a provider. Now, let me explain, because none of you know. Urgent means you're going to be seen really quickly. And then there's access, and there's just this cartoon. Our GP can squeeze you in a week after next. Access, what the payers, the companies are looking for is 72-hour maximum time before you see a specialist. And if you can't do that, that's going to be a huge problem. No longer is having a big waiting list a badge of courage. It's a problem when it comes to value. And then there's cost. UCLA just did a study. They found that 50% of their ICU patients who were admitted to the ICU were admitted unnecessarily. So these are the areas that you want to focus on, because if you're positioned well as an organization to offer great value, you're not going to have a problem in the future. Somehow it's going to work out. So what you need is the data. You all need to be on the same EMR, and you need to have physician governance. Physicians that can say, hey, you're not going to keep doing it. Like, I'll give you an example. In my pediatric group, if you get poor patient satisfaction, and we do patient satisfaction every year, The doctors will mentor you for 1 year, and if you still get poor patient satisfaction, you're asked to leave the group because you're going to ruin the brand. That's what we're talking about in terms of physician governance. So here's an example of value. How many of you have Yetis? Couple. This, by the way, if you don't, it's a coffee cup. It's a coffee cup. And if you want it, it costs $38 for a coffee cup. They're flying off the shelves. You put ice in it, the ice will last 24 hours, guaranteed. In order to sell these, you have to buy at least $6,000 worth of product, all their products, and you have to have 9 feet of shelf space, or you can't sell them. That's value. We tried to create value in orthopedics at Hartford Healthcare with orthopedics associates. We said, well, what can we do to make it attractive and add value to an orthopedic surgeon's practice? First thing we did is said, it's bone and joint only. We're going to create an orthopedic hospital. The physicians designed it. A physician leads it. Everything is state of the art. We joint ventured the office building with the physicians. We joint ventured an ASC with the physicians. There's a co-management deal, and they came up with this idea for 59 beds. That means if the patient's in the hospital for 23 hours, 59 minutes, they're still considered an outpatient. And it's actually going pretty well. It just opened, I think, in December. But that's value. That's what hospitals should be doing with their doctors. We're also seeing the emergence of more government. Now, if you get something with this stationery on it, it is not a birthday card. I can guarantee it. This is a really bad thing. And keep in mind, June 2015, this is like really important. The Office of Inspector Generals came out and sent the first fraud alert to doctors. And they essentially said, if you're getting a directorship and you're not spending the administrative time and making a difference, that's a sham directorship, and you could be in trouble. You could be in trouble like Columbus, Georgia, where an oncologist had to pay $425,000 of fines and the hospital had to pay $35 million. You could be in trouble like Broward County Hospital, where they overpaid doctors and had a fine of $70 million. Now, you may want to know what fair market value is, because as long as you're paid fair market value, you're okay. The government defines fair market value like they define pornography. We can't tell you what it is, but we'll know it when we see it. So if they come to your office and pull out your hard drives, there's a pretty good chance that they believe that you're not being paid fair market value. I have been blamed 1,000 times that I'm just using Stark and fair market value as an excuse not to pay doctors. I'm really not. This is a really major issue, and if it happens in your practice or it happens to you personally, it's going to be a huge problem. If you don't get anything out of this presentation other than this, be compliant, which means if you're getting a directorship, make sure you have a job description. Make sure you're reporting to somebody. Make sure they're evaluating you. Make sure you're spending, don't do what that cardiologist did in Maryland and just, I use the word Xerox, the same timesheet over and over again. Make sure you're spending the time, or at least appear to spend the time, on administrative work, because this is a huge issue and the government's warned you. So what's population health? Here's how I define population health. We say to these two completely different patients, we're here, come and get us, fend for yourself. They may even end up in the same waiting room. That's crazy. These people have different healthcare needs. This person over here should be in a frail elderly program, probably managed by a PA or nurse practitioner, overseen by a geriatric physician, with very specific protocols on how to treat her. This guy over here should only probably, can go to minute clinics, which by the way are failing miserably, or get virtual visits or something else. But let me explain what population health really is. Here's the old system. We had all of these sites of service. And it was basically a provider-centric system. Why is this provider here? Because they want to be here. Why do they provide care this way? Because they want to. And us patients, 69% of the patients said that they rely on themselves or a family member to coordinate care. as opposed to this model right here, which says we have people with MS. How do we design a delivery system using all of these sites of service to optimize care for a person who has MS? CEO said his wife has MS. When she gets a fever, her legs go numb. Other than that, she can walk. She called the MS doctor and said, my wife has a fever, her legs are numb. The MS doctor said, fend for yourself, call your internist. Called the internist, said, my wife's legs are numb because she has a fever. The internist said, bring her in. He said, can't bring her in, her legs are numb. So they ended up having to call an ambulance to take her to the ED. Why couldn't you create in a city an MS delivery system where you had experienced nurse practitioners visiting MS patients whose legs are numb in their homes? So think about this for your practice. How do you optimize using all of these sites of services, care for a knee or a joint or a hip replacement, or for a sports medicine procedure, or for a hip fracture, such that maybe they don't have to come in every time. Maybe you can do a virtual visit. Or maybe you can use somebody at the top of their license who's not a physician. So what I'm asking you to do very simply is to create a high performance in a clinically integrated network. Or in your particular case, participate in the hospital's one if it makes any sense at all. And a lot of times it doesn't. But this should also be for your practice. Think about this. Now, this applies to nobody here. But what guarantee can I have when I go to a traditional hospital? I can guarantee that my care will be no worse than that provided by their least competent physician. And I represent about a bunch of heart surgeons, and I know there's a level of competency there, and it scares the heck out of me. Not only that, they can't guarantee me that my care is going to be appropriate, efficient, state-of-the-art, affordable, or meet the highest professional standards. Or they can't even guarantee me that the physician treating me is going to be in-network. So here's what I'm asking you to do as a strategist and also as your patient. Create a network. Transform your practice such that wherever I go, whoever I see, I consistently get superior service, predictable, reasonable cost, appropriate, accessible, standard care based on the best science of medicine, that you're all digitally connected, that you have a virtual strategy so I don't have to come in post-surgery necessarily, that you have broad geographic coverage, so because I may work over here and I may live over here, and that you're all in-network providers. And my question is, as your patient, is that too much to ask? Is that an unreasonable request? And by the way, if you do this and you don't need it, would you have any regrets? And if you do this, then you're prepared for the squiggly line. So I encourage everyone to think about the Kaiserification scale. I made this up. And the reason I did is based on every rating that any regulator is using, Kaiser Northern California gets the best rating. In fact, 10% of the top 100 hospitals are Kaiser hospitals. So they must be doing something. Well, here's some of the things they're doing. They have an organized network, transparent, actionable analytics. They measure everything. They comply with hundreds of guidelines. They focus on care and collective performance. And they have an interconnected electronic medical record known as EPIC. One of my friends, Brad Shearer, his mother went to the ED at Kaiser. They discharged her. A couple days later, she was admitted. They eventually discharged her. 2 weeks later, she gets a call. Ms. Shearer, we're from Kaiser. We're calling to do a root cause analysis on why we failed you the first time. I think that's pretty cool. Now, on the other side of the equation is you have to create acronyms, right? So my acronym is a CCSI, a coalition of competing self-interests. It's characterized by limited geography, out-of-network providers, a culture of optionality, autonomy, and silos. Patients have to fend for themselves. We focus on individual compensation, and you have the traditional Israeli-Palestinian conflicts between administration and the doctors. And the question you have to ask, and all providers have to ask is, where are we today and where do we want to be on the continuum? That's your choice. I don't think you need to be all the way over. I think you need a nudge, though, because I think that's what people want to buy in the future. In fact, take a look at this. This is Medicare Advantage. 1 out of every 3 patients or people over 65 is in a Medicare HMO. And why is that? Because once you retire to when you pass away, on average, you spend $365,000 in the fee-for-service world out of pocket. So if you believe, as I do, that Medicare Advantage is only going to grow, you want to be like and act like the top Medicare Advantage provider networks. Here's a quiz. They identified the top 10 best Medicare Advantage networks. Take a look. See if you see anything in common among those networks. Right? Kaiser, Kaiser, Kaiser. Again, you need to have thoughtful conversations in your practice about where you want to take your costs, where you want to take your clinical effort, how you want to standardize your clinical efforts if you do, how you want to improve your service, how you want to improve access. So what's the magic? I gave this presentation a couple weeks ago, and the leader of a 4-physician cardiac surgery group came up to me and said, how do you get your partners to buy into this stuff? And I said to him, don't ask me. I mean, you're the head of the group. You figure it out, right? So the challenge we have both in hospital health systems and in medical groups is the challenge of I am versus we. In other words, I had an ENT appointment. The day I was going to that appointment, my physician, who was a member of Scripps Clinic, hurt his back. I travel a lot, so I needed that appointment that day. I'm not his patient, I'm the group's patient. And they should have called the other 13 ENT physicians and said, we're working late tonight to cover for this guy. Instead, I got a phone call and said, you're rescheduled for 6 weeks out. That's my practice in a group versus we. The problem is, as I look at physician practices, and most significantly, medical staffs, the vast majority of physicians are transactional. You want me to do something? Pay me. And I represent physicians in doing that. Thank you. The challenge, though, is this, that a purely transactional relationship teaches your affiliates the art of blackmail. The next group is apathetic. Then there's the 15% that you can never please under any circumstance. And then there's the few that get it. And the challenge you have, if you believe what I'm saying, is you want to move that we down and get more of them engaged. Now, when I study this, I like to use Chip and Dan Heath's concept. They wrote a book called Switch. They said when you want to make change, there's 2 components for an individual or an organization. There's the rider and the elephant. The rider's looking over the horizon, trying to see what's next, thinking about stuff, always looking for new ideas. And then there's the elephant that basically is a product, short-term thinking, product of their training. I'll give you an example. Like, I know I'm supposed to exercise, so during football season, I wake up on a Sunday morning and I say, well, I have 2 choices. I can go out and exercise or sit on my couch, eat Cheetos, and watch 3 football games. Well, my elephant tells me, usually wins, because the rider can't go anywhere without the elephant. And the reason I bring this up is basically in a health system, us suits are the elephants. Now, this is a gender-neutral term, even though I put a tie on them. We're looking over the horizon. We're talking about population health, triple aim, and all that kind of stuff. And thank goodness you're focusing on your patients. Appropriateness, outcome, service, and access. And so the challenge really is, how do we get everybody, whether it's in your group or in the health system, to really move away from the status quo? Now, I always recommend hiring a consultant, but really we don't have much of an impact. The answer actually is this: unblinded data and peer leadership. If you unblind the data, you're measuring cost, you measure the 4 benefits and cost, and you distribute that, and you have physicians talking to peers and saying, no, you can't have a patient satisfaction survey or an employee engagement survey like that and be in this group. You've got to fix it. You're going to be able to change the way healthcare is delivered, but that's not the culture. We're much more of a guild where everybody's kind of an artist as opposed to an organization, and that's going to hurt you in the long run. Almost done. So the key to this is physician leadership. One CMO said this to me, and I really like this: every patient is my patient. Think about that as a theme for your medical group. Every patient is our patient, and we'll make sure they get the 4 benefits. Regardless of it's me, if my grandkids get sick, they will see a pediatrician within 24 hours. Maybe not the one that they go to for well baby care, but they'll get to see him within 24 hours, and that's what I want. So what's the keys to physician leadership? It's not clinical expertise. First thing is they have to believe in this new model of care, or the right model of care. The second thing is they have to set an example. The third one is they have to have the right attitude. If you have the right attitude, you can learn the competencies. If you have the wrong attitude, it's not going to work. I see a lot of physicians talk, the physician leader, the lead physician is also hoarding RVUs. That's not going to work. They want to set direction and create an environment where it's easy for their peers to follow them. If it's not easy, it's not going to happen. They want to appropriately use their authority and accept accountability for results. And the most important thing for a leader is to be able to create followers. Because if you can't create followers, you're not really a leader. So let me give you a brief YouTube video of what it means to be a leader and a follower. Hopefully most of you haven't seen this.
If you've learned a lot about leadership and making a movement, then let's watch a movement happen start to finish in under 3 minutes and dissect some lessons. First, of course, a leader needs the guts to stand alone and look ridiculous. But what he's doing is so simple, it's almost instructional. This is key. You must be easy to follow. Now here comes the first follower with a crucial role. He publicly shows everyone else how to follow. Notice how the leader embraces him as an equal. So it's not about the leader anymore, it's about them, plural. Notice how he's calling to his friends to join in. So it takes guts to be a first follower. You stand out and you brave ridicule yourself. Being a first follower is an underappreciated form of leadership. The first follower transforms a lone nut into a leader. If the leader is the flint, the first follower is the spark that really makes the fire. Now here's the second follower. This is a turning point. It's proof the first has done well. Now it's not a lone nut and it's not two nuts. 3 is a crowd and a crowd is news. A movement must be public. Make sure outsiders see more than just the leader. Everyone needs to see the followers because new followers emulate followers, not the leader. Now here come 2 more people, then 3 more immediately. Now we've got momentum. This is the tipping point and now we have a movement. As more people jump in, it's no longer risky. If they were on the fence before, there's no reason not to join in now. They won't stand out, they won't be ridiculed, and they will be part of the in crowd if they hurry. And over the next minute you'll see the rest who prefer to stay part of the crowd, because eventually they'd be ridiculed for not joining. And ladies and gentlemen, that is how a movement is made. So let's recap what we've learned. If you are a version of the shirtless dancing guy, all alone, remember the importance of nurturing your first few followers as equals, making everything clearly about the movement, not you. Be public, be easy to follow. But the biggest lesson here, did you catch it? Leadership is overglorified. Yes, it started with the shirtless guy, and he'll get all the credit, but you saw what really happened. It was the first follower that transformed a lone nut into a leader. There's no movement without the first follower. See, we're told that we all need to be leaders, but that would be really ineffective. The best way to make a movement, if you really care, is to courageously follow and show others how to follow. When you find a lone nut doing something great, have the guts to be the first person to stand up and join in.
But it's critical for your medical group, it's critical for your group to find a leader and to find the followers and get to work on modifying your group from a group of condominiums. And let me give you one example. Because I negotiate with orthopedic surgeons a lot, they send me emails. And I can tell how groupy that group is by whether I'm getting one domain name or one guy has Gmail and another one has Yahoo and another one has AOL. You know, you've got to become a group and you've got to move as a team, and you're going to have to adapt to Lord knows what's going to come next. I can't predict it. So this is kind of humorous. And don't be like a hospital CEO and self-deceive yourself. This is a CEO who said, I read this article, it said, we are fully aligned and engaged with our physicians. I happen to know some orthopedic surgeons in the region. And I said, is that CEO really fully aligned and engaged with you? And essentially what he said is that's fantasy. The system's success is due to high rates they charge, not management or physician engagement. You know, so he's not going to go anywhere. He's basically convinced himself, hallucinated himself, if that's a word, into believing that their organization is great when in fact it really wasn't. And so he won't be prepared for the new environment. Well, how does this relate to docs? Well, think about this. How many times have I heard, my practice is full, I provide the best care for my patients? And the answer is, that may be true or it may not be true. And the whole effort on the part of payers, government and private payers, is to say, well, let's measure appropriateness, outcome, service, access, and cost and make sure. You will be measured on that as a group and as individuals. And you need to make sure that you've optimized all of those benefits and the cost. So 3 more slides and I'm done. Where's healthcare going to go? I don't have a clue, but I have some ideas. I think we're going to continue to see ineffective government programs and regulations. If you want to argue with me about that, you can. We're going to see pressure on revenues, which intensifies your need to focus on cost. Threats to hospital outpatient rates, which are better than practice rates, and also to the out-of-network loopholes. Rewards and penalty for performance risk. Here's your target. If you beat it, you get extra money. If you miss it, you're going to be penalized. Bundles and reference pricing, which is all about knees and hips and backs. More interest in narrow networks and tiering. San Diego school system has identified every orthopedic surgeon in the market and tiered them. So if they're tier 1, it means they're high quality, low cost. The patients don't have to pay a copayment. Tier 2, you have to pay a deductible. Tier 3, you have to pay a copayment and deductible. And that's happening across the country. Now, there's a reason why it's going to be tiering and not narrow networks. The reason for tiering is they've done this study, and the evidence is very clear that women change their spouses more often than they change their OBGYNs. And so if you tell a female workforce, oh, you can't go to that group of physicians any longer, they will rebel. And so tiering gives them the opportunity to fix that. Accelerate and move to electronic medical record, which has been a problem for me. All of my doctors know what business I'm in. When I go to the orthopedic surgeon and sit down on the exam table, what does he do? He starts bitching at me about the electronic medical record. Eventually, after 15 minutes, I say, would you mind examining me? My shoulder's hurting. Accelerated physician shortage, fewer small practices, no change in patient responsibility. Why? Because patients are also known as voters. Payers' market power is not going to decline, and I'm wondering if maybe we may get some relief on pharmaceutical pricing. And most important, affordability is still the primary issue, and it's not getting better. So here's a question that I kind of made up, which is your multi-million-dollar business a business or a collection of revenue-sharing silos? So here's my list. Do you have an excellent leader with authority and accountability to go to a physician and say, you know, your service isn't very good, you've got to improve it? Do you have shared governance where people feel like there's a fair process, where they're being treated fairly? That's 85%, 15% will never believe it. Do you have a culture of our practice? Are you geographically indispensable? Are you big enough to fight the insurance companies because they like to cull the herd and find small practices and pay them nothing? Do you have a hierarchy where you're actually doing performance reviews on your physicians to make sure they're meeting the standards? Are you using the advanced practitioners to the top of their license? Is everybody adhering to what you've mutually agreed as appropriate clinical guidelines? I call them guidelines because, listen, if you hit a flock of birds and need to land in the Hudson, then improvise. Do you have merit-based performance and a common workflow? Common workflow with respect to clinical, patient satisfaction. Again, if everybody does it differently in your office, that's waste, that's a cost, and that also creates errors and poor employee satisfaction. Do you have a common EMR and the same, it's supposed to be same and an email domain? And do you have a detailed succession plan? So your business is geared to thrive in the new environment. So let me finish with this. And this is a message I give to hospitals all the time. It's better to be late than incompetent. What I see in healthcare systems, which scares the heck out of me, is they're running into businesses that they have no business getting into, especially the insurance business. I think you have time as orthopedic surgeons to really create something that's differently better, but it has to be a group and not a bunch of individuals. Focus on getting sick care right at a much lower cost. That's ultimately what we're responsible for. All this wellness stuff, that's going to die on the vine just like it has in the past. Focus on those 4 benefits and cost, and whatever happens, you're going to be fine. Make sure you win the hearts and minds of your colleagues. If your colleagues don't believe in this, if you haven't found not only the leader but a couple followers, it's not going to happen in your practice, and they're going to think you're a lone nut. And the final point is railroads. Everyone said the railroads were crazy. They were crazy because they didn't consider themselves in the transportation business and get into the airline business. Well, the reason they didn't was because they were in the railroad business. Everyone from the janitor on up, all they knew were railroads. And that's okay. Railroads aren't obsolete. This is Norfolk Southern. It's owned by Buffett, Warren Buffett. Last year it made $2.4 billion profit. And the reason they did is they were innovative. These locomotives are like jet engines. They've consolidated. They've focused on efficiency. They focus on performance. And as a result, even though people thought they'd be obsolete, they're still a great business. We're always going to need doctors. We're always going to need orthopedic surgeons. We're always going to need a couple hospitals. And if we focus on improving our business and focus on adding value to the patients and to the payers, you're going to be just fine. Thank you very much.